Good morning and welcome to the National Press Theatre. I'm Stephanie Levitz. I'll be moderating today's news conference with the Canadian Organization for Rare Disorders. Before we begin, just a few important preventative measures to share. To prevent disruptive and potentially harmful audio feedback incidents that can cause injuries, we remind all in-person participants to keep their earpieces away from all microphones at all times. And when you are not using your earpiece, please place it face down on the middle of the sticker for this purpose you will find on the table. And with that, we will turn to today's news conference. Over to you.
Good morning. My name is Durhane Wong-Rieger, and I am President and CEO of the Canadian Organization for Rare Disorders. Thank you very much for being here, and thank you for the opportunity to speak. As you know, we call them rare disorders, but frankly, individually, yes, they're rare, but collectively, because there are thousands of them, altogether, they're not rare at all. About 1 in 12 Canadians has a rare disorder, which adds up to about 3.5 million Canadians. 2/3 of those diagnosed are children, meaning there are several million other Canadians who are parents of a child with a rare disorder, and additionally, millions more family members. Increasingly, also, rare disorders affect adults. So rare disorders are not really rare. They impact a large portion of Canadians. And that's why Canada's National Strategy for Drugs for Rare Diseases is so really important. It's been helping Canadians, providing up to $1.5 billion in funding to national programs, as well as provincial and territorial drug programs. So we're now just about the halfway point of that strategy, the first 3 years of funding, from April 24th to March 2027. And thanks to the bilateral agreement between the federal government and every province and territory, many Canadians now have access to 9 important treatments for some very serious rare disorders, as is detailed in our press release. And for us, this is really great progress. Health Canada is providing strong leadership for the strategy, and I'm pleased to have been part of the implementation advisory group, an indication of the important contribution of stakeholders to the rollout. But I think, as we know, a whole lot more needs to be done. Many of the patients do not benefit from the treatment, even though these treatments are funded. They're in the provincial and territorial plans, because frankly, they just are not diagnosed. They don't get diagnosed in time, and quite frankly, by the time they get diagnosed, many of them will have been very severely impacted by the disease. The terms of the national strategy do call for provinces and territories to screen and diagnose, but frankly, most of those initiatives have not been implemented. So CORD, on behalf of our patient community, along with the healthcare community, is committed to working with the provinces and territories toward timely diagnosis and treatment access, as well as data collection programs to capture real-world use and outcomes. This will let us assure that those patients who are on therapies are actually getting the benefits that were intended, and quite frankly, that we can collect information to show that there's an economic and societal return on that investment. CORD's recent national survey, which was conducted by Ipsos, found that living with a rare disorder imposes a disproportionate toll on parents, patients, and families in comparison to those without a rare condition. Our families spend thousands annually on out-of-pocket medical services and prescription drugs, and over 1/3 require more than 4 hours of unpaid caregiver time every day. Underscoring the challenge of diagnosis, more than 2 out of 5 patients report that they have been misdiagnosed before they got an accurate diagnosis. And on average, it took about 7 visits to a family physician, 7 visits to medical specialists before they got an accurate diagnosis. We can do a whole lot better. A recent U.S. survey found that earlier diagnosis and treatment reduce long-term costs for both families and the health system. So the earlier you can get diagnosed and get access to treatment, the better, obviously, for the patients and the families, but also it has a real impact in terms of savings to the health system. And those were the same findings that were in a European study that was done recently. So earlier access to treatment for rare diseases reduce the overall burden. I mean, that's why we're working here as CORD, patients and healthcare community, to ensure that the second half of our first 3-year plan is going to focus on improvements in screening and diagnosis. We're also all here to start planning for phase 2 of the strategy beyond 2027. We want to ensure that the federal government continues to direct funding for drugs for rare diseases, as well as create comprehensive coordinated care models to make a real difference for patients. I think that we would all agree that caring for Canadians is not just a 3-year project. It must be a key part of our healthcare system for many years into the future for the benefit of all Canadians. We at CORD are ready to work with the federal and provincial and territorial governments to make that happen.
Merci beaucoup, Durhane, et bonjour à vous tous. Merci beaucoup d'être là et de vous intéresser aux enjeux qui sont importants pour les Canadiens touchés par les maladies rares. Nous pouvons tous être fiers que la stratégie nationale visant les médicaments pour le traitement des maladies rares aide maintenant les patients canadiens, en particulier ceux et celles qui sont traités par les médicaments inclus sur la liste commune. Toutefois, comme on l'a dit maintes fois avant, la stratégie ne se limite pas aux médicaments. Elle prévoit également un financement important afin d'améliorer le diagnostic et le dépistage. Et à ce jour, nous n'avons pas vu suffisamment des mesures visant ces stratégies-là et des voies d'accès aux soins. Ce sont des éléments clés pour aider les familles qui doivent faire face à beaucoup trop de défis avant même d'arriver à l'étape d'un traitement. Un récent sondage national de l'Organisation canadienne des maladies rares qui a été réalisé par Ipsos précise qu'il faut maintes et des maintes visites à des professionnels de la santé pour obtenir un diagnostic précis. Et cela entraîne des lourdes répercussions sur les patients, la famille et la communauté, mais aussi le système de santé. À l'Organisation canadienne des maladies rares, nous sommes déterminés à aider à améliorer le diagnostic partout au Canada. Et ceci va être la stratégie et notre priorité sur la stratégie nationale. Nous avons aussi hâte de planifier la prochaine phase de cette stratégie, au-delà de 2027, en nous assurant que le gouvernement fédéral continue de garantir un financement direct et durable pour les médicaments et de créer des modèles de soins plus complets et coordonnés afin de vraiment changer les choses pour les patients et leurs familles. Dans mon travail quotidien avec les familles touchées par le syndrome de Loeys-Dietz, qui est une maladie génétique rare qui affecte le cœur, les vaisseaux sanguins, les os, les articulations et la peau, j'entends toujours les mêmes histoires. Des parents épuisés qui ont passé des années à chercher une réponse. Des jeunes qui naviguent un système où la génétique, la cardiologie, l'orthopédie, la chirurgie ne se parlent souvent pas. Des patients qui doivent quitter leur province pour obtenir une évaluation vitale. Ce sont des défis évitables. Parce que lorsque les familles sont diagnostiquées tôt, lorsqu'elles ont accès à un dépistage systématique et des équipes de soins coordonnées, on peut prévenir des catastrophes, des dissections aortiques, sauver des vies et permettre aux enfants atteints de ces maladies rares comme le Loeys-Dietz de devenir des adultes en santé, épanouis et actifs. Nous pouvons et au fait, nous devons faire davantage pour ces patients et leurs familles, ainsi que pour tous les autres Canadiens qui sont pris avec des maladies rares. Ce n'est pas seulement un projet de 3 ans, nous devons en faire un élément important de notre système de santé pour de nombreuses années à venir. Et ceci dans l'intérêt de tous les Canadiens. Mon nom, c'est Jida El Hajjar et je suis la directrice générale de la Fondation Loeys-Dietz Canada et je suis la présidente du conseil de l'Organisation canadienne des maladies rares. Merci.
Thank you. I am Jennifer Adams, a family physician in Ottawa and an advocate for Primary Hyperoxaluria Canada. My family's journey has been profoundly affected by access to a rare disease drug on the common list of the National Strategy for Drugs for Rare Diseases. After 18 months of multiple tests, visits with specialists, dismissed by a system that I worked in every day, my daughter was diagnosed with primary hyperoxaluria type 1, PH1, a rare and life-threatening genetic condition. It felt like we were handed a rickety raft and told to cross the ocean. Without treatment, our daughter faced a terrifying future of excruciating kidney stones, irreversible kidney damage, and the looming need for dialysis and kidney and liver transplants, or even death. We were trapped in a state of fear. Our rickety raft would capsize with her next infection. Her next blood work would reveal a gaping hole we couldn't repair. As parents, we felt helpless. We were lost in the dark, treacherous waters of life with a child with a rare disease. Then came lumasiran, Oxlumo. This life-changing medication became our lifeboat, offering safe passage. My daughter's quality of life improved, reduced hospital visits, and no doubt has delayed and more likely eliminated the need for costly dialysis or transplants in the future. My husband was able to return to work, and we began to live a normal life. It's a journey only available to a fortunate 5% of rare disease patients, as 95% of rare diseases have no effective treatment. We are eternally grateful this miracle drug exists. The National Strategy for Drugs for Rare Diseases is our lighthouse. With the list price between $100,000 to $200,000 per dose every 3 months, lumasiran is a passage most cannot afford. The strategy's light keeps us from crashing into despair, allowing us to stay afloat. But the supply is limited, $1.5 billion over 3 years. Funding meant to keep this lighthouse shining. And while it may be tempting, even well-intentioned, to share that limited supply beyond its purpose, there's much to get done, much that was promised. Without it, families are left to drown. Our daughter and all rare disease patients deserve a reliable, sturdy lifeboat, and we need a lighthouse to guide the way to hope and safety. Keep the light burning. Thank you.
Thank you to the three of you for sharing your points of view with us this morning. Ordinarily, I would turn to questions in the room, but I see none from my colleagues, nor do we have anybody online. So I will take my privilege to ask a couple of questions, if I might. First, just a factual one. I wonder over the lifespan of the strategy right now, if you can say how many people have been helped and received the access to the care they needed because specifically of this strategy. Do you know?
I don't think we have an exact number. We are waiting for the provinces to report back on the first year of the funding.
Yeah.
What we do know is that there are 9 rare diseases, drugs that have been included, including Oxlumo, as Jennifer talked about. We know that these are available, not all 9 of them, across all the provinces, but definitely hundreds of patients have been able to get access, and there are quite frankly hundreds more that could be eligible, but some have not been diagnosed, some have not yet been prescribed for care. So we'll wait and see what the exact numbers are that are coming out. Not all $1.5 billion is going to these 9 drugs. There is much more of the monies that can be used for diagnosis and screening. And also a good portion, maybe 40% of the monies, is allocated toward what they call either leveling the care that's already, treatments already available across provinces, because we don't have a uniform, access, but also for new and emerging drugs, which of course continue to be made available. So I don't know an exact number, but we do know there are literally hundreds of patients that have been able to benefit.
Maybe just to pick up on that, the new and emerging drugs, I think it's been reported and discussed a lot in this country about how long it takes for drug approvals here. And the question of, I mean, there's two elements of that. I'd welcome your thoughts on. One, there used to be a time when people would say, why can't we just, if it's approved in America, why can't we just use it here? But now, with what's happening with American politics and healthcare, I'd welcome your thoughts on whether that's still a realistic way to approach drug approvals in Canada, to trust American data.
I don't think the data are necessarily different, because one of the big advances we've been able to make in the US and elsewhere in Europe as well is that we can accept global data. And for rare diseases, you almost have to have it because the numbers are so small. The value of having Canadian data is the fact that clinicians have been involved in clinical trials, so they have experience with the drug. So when it comes available to be used, we've got a network of clinicians who know how the drug works. The patients are already on it. So for us, getting clinical trials in Canada is hugely important, not just for the data, but because we want to have the experience. And of course, it's early access. I think, as Jennifer indicated, it's the only drug. And so for a patient to get into a clinical trial, that is absolutely a miracle in and of itself. And what we have experienced and what we are really excited about is that Health Canada actually does approve in a very timely fashion. Once upon a time, we would have to kind of wait much longer. So Canada does have an accelerated process for what they would call, life-threatening rare disease drugs. They have a pathway that is faster. I think we also have a lot of mutual kind of recognition, sharing of the data. They're able to take a data file from the US, bring it into Canada, fold it into the regulatory process, which we think actually is much more safe. And so as long as they're timely, as long as they can do it to the same standards, I think it really is a benefit to have Canada having had the regulatory expertise, because many of the drugs also require ongoing monitoring and follow-up. So now they understand what they're looking for. And sometimes their approvals are not exactly the same as what the US has, not exactly the same as what Europe has, in part because we also have a different system. So our goal is for Canada to work as quickly and as well as any other countries. For some ultra rare conditions, I think we do say, okay, we can accept the data file. But I think Canada, I give them a lot of credit, has really moved up to be able to do as much as possible to be able to share data and contribute also outward. So we have a few drugs that actually come to Canada first. And so then we've got a data set that can also be shared.
And then just to pick up on this theme, and this will be my last question, just reflecting back then on what happened in British Columbia in the summer with the little girl, I believe her name was Charlie. And there it was Canadian medical experts saying, no, this drug is no longer applicable in this situation. And the government went and got advice and took it from elsewhere. So how do you navigate that?
So we were very much involved in the situation. And so let me kind of make it a little bit clearer in terms of what actually happened, right? There are criteria for the drug being made available. There were, at the time, some 7 or 8 years ago, some criteria for what the patient would need to continue to demonstrate in terms of responses to be able to continue on the drug. But the requirement was made at the time the drug was approved that we would do ongoing real-world collection of information to be able to demonstrate that the drug actually still works and that the criteria is the same. So to be absolutely accurate, there were, when this came back to the drug agency, Canada Drug Agency, to reassess. So there was a request made. She was being taken off the drug. Quite frankly, her clinicians and the other experts in Canada said she should stay on the drug. It was not the doctors that were experts in that drug that were saying she should be taken off the drug. And they actually made the application back to the Canadian Drug Agency to say, here are studies, can you review them? They submitted 9 studies. 8 of them, even though they were published studies, the Canadian Drug Agency rejected because they didn't like the study design. They didn't see that there was a placebo. They didn't feel like some of the measures being used. We made the argument that what they were using as standards for post-market real-world studies was not appropriate, especially for a rare disease drug. I cannot do placebo drugs. I cannot do that kind of comparison that you want. And certainly the experts in the disease in Canada were all saying Charlie should remain on the drugs. The doctors that said no were the doctors that were advisors to BC's agency, and I know some of them, and they're great doctors, but they were not experts in this disease. They were using criteria that was very much grounded in terms of what the process was, so they were much more process-oriented as opposed to actual evidence-oriented. And I don't think it's their fault. I think we do not have a system that actually reviews rare disease drugs, continues to evaluate it to the standards that the rare disease drugs need. We have long advocated for the need for having a unique pathway for rare disease drugs. Many, many countries have this. Same data set, the same timing in terms of Charlie's case with this disease in England, NHS. They're evaluating 5 years of post-market data, and they will come back with a determination for this same drug and for these same diseases. So the failing was not Charlie, the failing is the system, and the doctors who rejected it are great doctors, but they're not experts. The experts say yes, stay on the drug.
Thank you very much for your time here this morning. In case you want me to say it formally, that brings an end to today's news conference. Okay.
Okay.